Dear colleagues, ladies and gentlemen, welcome to the APLA webinar. My name is Laishan Tam. I'm the convener of the APLA Academy, as well as the APLA SPA SIG. So we are very pleased to welcome all of you to this webinar organized by the APLA SPA SIG. So today, we are going to focus on advances in imaging for the diagnosis and management of axial spondyloarthritis. And I'm very pleased to have Professor Paul Bird to co-chair with me. So Professor Bird is a rheumatologist and researcher from the University of New South Wales in Sydney, Australia. And he has a lot of experience in MRI. And so we are very happy to have him with us today. So Paul, would you like to say a few words to our audience?
Yeah, love to. Thank you, Laishan. Thank you for having me along. Very excited about today's talks and looking forward to learning as I see our speakers present today. So thanks again for inviting me to co-chair.
So thank you, Paul. So today, we are very honored to have two outstanding speakers. And so the first one is Professor James Griffith, and the second one is Professor James Chung. So let me introduce them to you one by one. So Professor Griffith is the chairman and professor in the Department of Imaging and Interventional Radiology at the Chinese University of Hong Kong. So Professor Griffith is expertise in all aspects of musculoskeletal imaging, from radiography, ultrasound, CT, MRI, through to PET imaging, as well as the basic interventional musculoskeletal techniques. Professor Griffith is also the immediate past president of the Asian Musculoskeletal Society, Global Regional Outreach Program Coordinator of the International Skeletal Society, and the subcommittee of the European Society of Skeletal Radiology. And he also served as the editorial board members in a number of very prestigious journals. And he's a first author or co-author of over 300 articles with an H index of 46. So we are very happy to have Professor James Griffith with us today. And then I would like to introduce our next speaker, Dr. James Chung. Dr. Chung is a medical consultant in Chiron Medical. He received his Doctor of Medicine and specialist training in Hong Kong, and he was a clinical assistant professor at the University of Hong Kong and associate consultant at Queen Mary Hospital. He's a council member of the Hong Kong Society of Rheumatology, and he is also a member of the APLA SPA SIG. And he's also the associate editor of the Journal of Clinical Rheumatology and Immunology and International Journal of Rheumatic Diseases. His areas of interest include application of MRI in axial spondyloarthritis, and he has been published in prestigious journals, including the Annals of Rheumatic Diseases, and won a few prestigious awards as well. So we are really, honored to have two outstanding speakers with us today, and so they are going to talk about. First of all, Professor James Griffith will talk about utility of low-dose CT on axial SPA assessment, followed by Dr. James Chung talking on the utility of MRI in axial SPA assessment. So we welcome all of you to have questions during the presentation using the Q&A function. And then we will have 30 minutes Q&A sessions at the end after the two speakers have finished their presentation. So now, without further ado, may I call upon Professor James Griffith to deliver his talk entitled Low-Dose CT for Assessment of Axial SPA SI joint. So Professor James Griffith, please.
Thank you. Thank you, Alice, for the very kind introduction. I hope you can all hear me okay. So we're going to talk about low-dose CT of the sacroiliac joints. Just to recap a little bit on anatomy, the sacroiliac joints are very important stress risers between your lower limb, your pelvis, and your spine. In fact, they're the joints in your body which are probably under the most stress of any joint. So it's not surprising that they're very prone to osteoarthritis, prone to stress-related changes, and because they contain quite a lot of synovial tissue, as well as enthesis, they're also prone to inflammatory arthropathies, including spondyloarthropathy. Now let's have a look at the anatomy in a little bit more detail. The sacroiliac joints, as you know, are composed of both synovial and ligamentous components. As a general rule, the ligamentous component is at the posterior and the upper part of the sacroiliac joints, whereas the synovial component, which is larger and involves about 2/3 of the sacroiliac joints, is primarily anteriorly and also towards the lower aspects of the sacroiliac joints. So if you look at a CT through sectioning through the upper, mid, and lower parts of the sacroiliac joints, what do you notice? Well, the first thing you notice is that the sacroiliac joints are aligned at an angle to the true coronal plane. So it's not surprising that if you do an AP view of the pelvis, how you will not be able to outline the sacroiliac joints clearly on both views. And so that's the reason why people used to use oblique views of the sacroiliac joints. But if you also look at the sacroiliac joints, you can appreciate the sacroiliac joints are considerably undulating, particularly in the middle 1/3 and the lower 1/3. So you can also appreciate that even with oblique views of the sacroiliac joint, that you still cannot see the joint margin very clearly. So nowadays, people tend not to use oblique views of sacroiliac joints and you tend to use a frontal projection of the sacroiliac joints to look for sacroiliitis. Now, again, if you look, as we mentioned, the sacroiliac joints are both ligamentous and synovial, have both ligamentous and synovial components. In the upper 1/3 of the joint, the anterior 1/3 is primarily synovial, whereas the posterior 2/3 is predominantly ligamentous. And in the middle 1/3 of the joint, the anterior half is synovial, whereas the posterior half is ligamentous. And at the inferior aspect of the joint, all of the joint is synovial based. Now, so if you look at radiographs of the sacroiliac joints and you take a group of patients with, highly selected group of patients with suspected spondyloarthropathy, about 15% of these patients will show unequivocal sacroiliitis, as you can see here, with irregularity, particularly on the right-hand side of the sacroiliac joints, and fusion and also sclerosis. But the main feature, honestly, is irregularity with erosion to the sacroiliac joints and also some fusion or ankylosis of the upper aspects of the sacroiliac joints. So unequivocal sacroiliitis. About 35% will be normal, in fact, that show completely normal appearance, no evidence of erosions or ankylosis on both sides, unequivocally. But a large percentage, particularly if reported by, radiologists say less experienced or with reporting sacroiliac joints, about 50% of the joints will be reported as equivocal. In other words, they don't show definite evidence of sacroiliitis, or neither can they be called definitely normal. So that's a problem with assessment of the sacroiliac joints with radiographs. Is a large number of them are called either probably normal or possibly sacroiliitis, and without being unequivocally normal or abnormal in either regard. What other possibilities can you use? Well, what about low-dose CT? With low-dose CT, you can see, even though the dose provided is low, you can see, because there are multiple sections throughout both sacroiliac joints, you can see very clearly the margins of the sacroiliac joints bilaterally in this patient, this normal CT examination. Now, CT, as you know, has been around since the 1990s, but low-dose CT has only been become available in the, in the last 5 or so years. What do you mean by low-dose CT? Well, effectively, the radiation dose is not much greater than the radiation dose that you achieved with radiographs. You can do this by using features such as thin filtration, iterative reconstruction, which achieve dose reductions of about 85 to 95% compared to standard CT. Now, so it's basically because you give the patient a very low dose of radiation, the initial image is very noisy, as you can see here. But then by using sophisticated post-processing algorithms, you can reduce or eliminate most of the noise, so you get a very clear definition of the margins of the sacroiliac joints, as you can see here. So low-dose CT can typically be done for doses of less than 1 millisievert, which is considered a minimal risk. In other words, it's about 1/3 the annual exposure to natural background radiation, which is about 3 millisieverts. In our hospital, the radiographs of the sacroiliac joint, the dose is 0.05 millisieverts for a radiograph of the sacroiliac joint, whereas the low-dose CT of the sacroiliac joint is about 0.3 millisieverts. So it's roughly equivalent to about 6 radiographic examinations of the sacroiliac joints. But as I will point out to you, the utility of low-dose CT is much greater than that of radiographs. So it generally makes this increased radiation dose worthwhile. What does low-dose CT show you? Well, the main thing it shows you is erosions of the sacroiliac joint. Now here, there's no erosions along this part of the sacroiliac joint, but here you can see clear erosions on the iliac side of the sacroiliac joint and on the sacral side of the sacroiliac joint down here. It can also show unequivocal ankylosis or bony bridging across the sacroiliac joints. And it can also show erosions or sclerosis, but the sclerosis is a common and relatively non-specific finding. With regard to erosions, it's the presence and the degree of erosions, it's the number and the degree of erosions rather than the simply presence of erosions that are important, because a lot of things like subcortical cysts or osteoarthritis can give erosions or subarticular erosions. So you have to consider the number of erosions and also the sort of severity of these erosions. Also, with respect to ankylosis, it's not completely specific because, again, ankylosis may occur in the setting of more advanced osteoarthritis. But in osteoarthritis, the ankylosis tends to be either at the upper or lower aspects of the sacroiliac joints. Whereas if you get ankylosis in the mid portion of the sacroiliac joints, it's a very specific sign of inflammatory arthropathy. Now, ideally, radiographs should replace, or low-dose CT should replace radiographs for the initial assessment of sacroiliitis because there's much higher reliability with respect to detection of erosions and ankylosis, and as a result, higher diagnostic capability than radiographs. This is our experience of 42 highly selected patients with clinically suspected SPA. Now, these are just looking at the radiographs, and when less experienced radiologists reported the radiographs, 15% were reported as definite sacroiliitis, 35% as normal, and 50% were considered to be equivocal. In other words, possibly normal or probably normal, or else possibly sacroiliitis. Now, when the same radiographs were reviewed by an experienced radiologist, the figures were slightly different, or considerably different, in fact, but the main thing is the number of equivocal radiographs was much less. And this was done in the sort of knowledge that giving it an equivocal report is really very little help in the actual clinical setting, that you need to have a much more definitive assessment of sacroiliitis. So whilst even though CT may not always be completely equivocal, the number of equivocal examinations with CT are much less, or even in experienced hands, a reasonable percentage of radiographs will be considered equivocal. Now, if you look at the radiographs, the reporting of the radiographs with an experienced radiologist and also low-dose CT, you can see the numbers are fairly comparable across both modalities. However, if you look at it, which was surprising to me, that if you look at those patients with normal radiographs, in other words, these are highly selected patients with clinically suspected SPA, they have normal radiographs, but 2% of these patients 11% or 2 of these patients had CT evidence of sacroiliitis. So even patients with unequivocally normal radiographs can still have sacroiliitis on low-dose CT. And similarly, if you look at those patients, and probably even more worrying if you look at those patients with unequivocal sacroiliitis on radiographs, 2 of these patients, or 13%, had unequivocal, were unequivocally normal on low-dose CT. So in other words, patients with what is thought to be unequivocal sacroiliitis on radiographs can be normal when they undergo low-dose CT. So this is an example here. You can see this patient, the radiograph looks relatively normal. There's some ankylosing at the top of the joint, but that may be due to osteoarthritis, but no clear erosions. However, on low-dose CT, you can see very clear evidence of ankylosis involving both sacroiliac joints. So CT is definitely, what about CT versus MRI? Well, MRI, can show you erosions of the sacroiliac joints, but CT is more specific than, low-dose CT is more specific than MRI in this regard. So low-dose CT is useful when MRI examination is equivocal. As in this case here, this patient was a young athlete. You can see there's a lot of osteitis alongside the sacroiliac joints. No, otherwise the sacroiliac joints looks unremarkable. However, on low-dose CT, you can see clear erosions of the anterior and upper aspect of the sacroiliac joint, indicative of an inflammatory osteoarthritis rather than, or spondyloarthritis rather than stress-related changes. Now, nowadays, we have what are known as erosion-specific MRI sequences, which are very thin, gradient echo sequences, which are more sensitive than standard T1 and T2 weighted sequences at evaluating the bony cortex of the sacroiliac joints. So these erosion-specific MRI sequences, which you can see here, compare very well to low-dose CT with respect to sensitivity in detecting erosions. And this is another example here. Again, you can see very clear erosions on both sides of the sacroiliac joints, though particularly the right-hand side. Also coming in the future is what's known as synthetic CT, where you can obtain an MRI image, and by elaborate post-processing procedures, then convert that into a CT looking image. So this is a T1 weighted MRI examination, and then using post-processing, you can convert that MRI image into a CT looking image, which are clearly very good for detecting erosions and is very comparable to the standard or real CT with respect to this. So this will become available in the future as an additional add-on to MRI examinations. Now, it's also, I'd like to express to you how it's not always easy to make a definitive diagnosis of sacroiliitis on CT or MRI. That you can still come across cases that it can be quite difficult to determine one way or the other. These are all cases which definitely do not have sacroiliitis. They're all patients who have just underwent routine abdominal pelvic CT examination for middle-aged to elderly females. And you can see that they've got quite bad joint space narrowing, marginal osteophytosis, some erosions present. And on the coronal sequence, you'll also see ankylosis. All of these features are all due to osteoarthritis. And similarly, the sacroiliac joints, because they're under considerable stress risers, are also prone to osteitis condensans ilii. And here you can see features of that. You can see erosions with periarticular severe periarticular sclerosis, and naturally, as you would expect, the coexistence of osteitis condensans ilii and osteoarthritis is not uncommon, is not that uncommon. So you will also see features of erosions due to osteoarthritis in the presence of osteitis condensans ilii. So it can be difficult in these situations to ascertain whether you're dealing with not an osteitis condensans ilii or a sacroiliitis. But these are the sort of relatively smaller numbers. And all of these patients, again, do not have an inflammatory spondyloarthropathy. They're all from routine abdominal pelvic CT examinations, all due to osteitis condensans ilii. The disadvantage of low-dose CT is that it cannot detect osteitis or enthesitis. In other words, it cannot detect the inflammatory components of spondyle or sacroiliitis. So one can argue that if low-dose CT is normal or equivocal, then MRI may still be necessary. And if you're following up a patient with known sacroiliitis and you want to see the response, then clearly and ascertain whether the level of inflammatory change is present in the sacroiliac joints, then clearly MRI is the best way to go in this regard rather than low-dose CT. Here's an example of osteitis around the sacroiliac joints bilaterally. And here you can see in this patient there's enthesitis, because this is the ligamentous portion of the joint posteriorly, and also enthesitis at the ligamentous attachments towards the more inferior extra-articular part of the sacroiliac joint. Now you may be wondering about what about dual energy CT? Well, dual energy CT potentially can show oedema, but it's certainly not as definitive as MRI in this regard. This is a low-dose CT, and oedema of the bone marrow is shown as red pixels, whereas this is a corresponding MRI examination, and you can see the bone marrow edema much more clearly than you can on low-dose CT. Also, than you can on dual energy CT. Also, dual energy CT cannot be low dose, so there's no way at the moment that dual energy CT will replace MRI for the detection of periarticular oedema in sacroiliitis. So, in conclusion, I feel that because it has much higher reliability, that ideally, and the radiation doses is only marginally greater, that ideally low dose CT should replace radiographs for the initial assessment of sacroiliitis in patients with suspected spondyloarthropathy. If access to MRI is limited, then low dose CT is helpful in these patients. But specific criteria for referral for low dose CT should be adopted. Low dose CT in these select group patients will tend to show sacroiliitis in about 40% of these patients. And in this situation, it may be reasonable to stop and do not proceed for further investigation at that in those patients. However, if low dose CT is normal or equivocal, then there may be an argument for proceeding to MRI examination. If access to MRI is not limited, then MRI is ultimately the better investigation, because it will show you everything really that low dose CT will show, and also show you evidence of inflammation around the sacroiliac joints, which cannot be evaluated with low dose CT. And also in certain situations, particularly patients with osteoarthritis or osteoitis condensalia, when it's difficult to ascertain completely whether to exclude or confirm the presence of sacroiliitis, CT in those patients may be useful, or low dose CT in those patients may be useful for problem solving. Thank you very much for your attention. Thank you.
Okay, thank you very much, Professor Griffith, for your very comprehensive talk on the utility of low-dose CT for the assessment of sacroiliitis. So we will be back for the next speaker. So Dr. James Jung. So he will speak on the utility of MRI in axial spondyloarthritis assessment. So while we are waiting for the slides, so there it is. So Professor Dr. James Jung, so the podium is all yours. Thank you.
Thanks, Professor Tan, for the kind introduction. I'm Dr. Jung Ho Yin. I am a rheumatologist. So this is my declaration. Now, MRI has been used as increasingly important clinical imaging tools for the assessment of axial spondyloarthritis. It has a very unique role in early disease diagnosis, disease classifications, and monitoring of disease. One of the reasons behind is so far it's the only disease assessment tool that has been validated with histological inflammatory cellularity in tissue biopsy of SI joint. So in this talk, we're going to talk about the application of MRI in various aspects, including disease diagnosis, disease activity assessment, disease activity monitoring, and for the future trend, personalized medicine of MRI. So the first part is disease diagnosis and how we're going to use MRI for early disease diagnosis. As all of you can tell, the traditional way to diagnose spondyloarthritis or ankylosing spondylitis is X-ray. So we have a very classical modified New York criteria for disease diagnosis. So basically, the slide shows you 3 stages of SI joint X-ray changes. So the initial stage was grade 0, so the SI joint was normal. There was no change in the SI joint, and then by time there will be erosion, sclerosis, as well as joint space changes, either narrowing or widening. And then the final stage, there will be a partial or complete ankylosis. So by that time, everyone will know this is ankylosing spondylitis. Now, the good thing about X-ray LS spine is a very inexpensive and a convenient method for disease diagnosis. It's easy to diagnose, but then the interpretations could be difficult. Is as suggested by Professor Griffith, the interpretation is very operator dependent, and it all depends on the experience of the interpreter. In addition, the imaging is associated with very significant delay of diagnosis, and it could be from the data, it could be up to 6 to 7 to 11 years. And because of this, MRI has been used to has been proposed for the early disease diagnosis of axial SpA. So this is the image of MRI that we frequently use for disease diagnosis. The SI joint MRI is a short pulse inversion recovery sequence, and we can also use a fast suppression T2 sequence. And what we see is the hyperintense signals of the SI joint, and basically the hyperintense signals here represent disease activity, so bone marrow edema. Apart from that, we can also watch out for erosions, sclerosis, or ankylosing, which could be the features associated with ankylosing spondylitis. Because of the development of MRI in 2009, Axis actually incorporate MRI into the classification criteria for axial SpA. And I'm sure all of you will know this criteria well. So psychoanalysis and imaging, including MRI, is one of the entry criteria of the classification criteria. Now, apart from the traditional SI joint MRI, we also use spine MRI for disease diagnosis. So this is one of our recent publications in 2020. We proposed using MRI spine for the diagnosis of SpA. What we see is this corner inflammatory lesion, so inflammation at the corner of the spine. What we see is a cutoff of more than 5 whole spine corner inflammatory lesions, or more than 3 thoracic spine corner inflammatory lesions could be compatible. Could have a compatible specificity to SI joint MRI. Now, similarly, we can use T1 image. So the last one was T2 image. So we can use T1 image for disease diagnosis. So this is another earlier publications in 2019. We proposed using fatty corner lesions for the axial spondyloarthritis disease diagnosis. And what we found is just like similar to the T2 image, patients with more than 3 anterior thoracic fatty corner lesions, or more than 5 anterior whole spine fatty corner lesions could have improved sensitivities or similar specificities with the SI joint MRI image. Now, having said that, we're not proposing to replace this spinal MRI with the SI joint MRI, but it just happened. If it just happened, patients have performed spine MRI with a lot of these lesions. Our proposal is, probably we don't need to go ahead for the SI joint MRI because the answer is already there. Now, apart from disease diagnosis, we could use MRI for disease activity assessment. The reason behind is the very classic study. This study published in 2000 is in the Annals of Rheumatic Disease. So what this study shows is patients with higher MRI disease activity score got a higher inflammatory cell counts upon SI joint biopsy. So basically, index B patients got a higher disease activity score in MRI, and from their biopsy result, they also showed more inflammatory cells when compared to the index A patients who has lower disease activities in both MRI and biopsy. Now, what about other disease assessment tools. So we have a lot of disease activity assessment tools. The clinical one, like the baseline, the XSTARS, could be a CRP, the ESR. These are the things we perform commonly in the daily clinical practice. Now, in 2017, we actually have a study. We tried to validate these disease assessment tool with MRI information, so either SI joint or spine MRI information. What we find is these disease activity assessment tools, basically they have no discriminative values in terms of whether in terms of whether patients got MRI defined informations or not. So basically, they cannot tell, using these tools, they cannot tell whether patients got active inflammation or not, apart from the C-reactive protein, which has a very mild, discriminating abilities. As you can notice, the AUC of the CRP when compared to the MRI informations is only 0.626, so it's only slightly better than the cone. So this is how we assess disease activity. So basically, we use the same sequence, the T2 stir sequence or fast suppression sequence. We can image the SI joint or the spine. So again, the one with a hyper intense signals basically shows active disease. So this is the SI joint disease activities, demonstrate by the T2 stir image. As you can see, but there are bilateral SI joint bone marrow edema, which basically shows an active disease. Similarly, spine, again, hyperintense signals in the thoracic spine. So, basically that shows imaging disease activities in the MRI. Now, having said that, there's still a lot of things we're not sure about this MRI disease activity assessment. So this is one of the recommendations from the UK Society of Rheumatology. The point I want to bring out is the point number 8. So this is kind of a no research agenda, something we need to research. There are quite a number of disease activity lesions in the MRI, especially spine. At the current moment, we are still not sure. So we're not still very sure about which one is stress or mechanically related and which one is related to disease activity. So this is the area we need to have more data before we can accurately assess disease activities. Now we can also use MRI for disease activity monitoring. This is earlier EULAR recommendations for the use of imaging in axial spondyloarthritis. And if you can take a look at the point number 3, they also recommend MRI of the SI joint and the spine for disease activity monitoring. Now, having said that, we do not do this routinely, and we do not recommend this routinely because of a number of reasons. Obviously, that would be the availability of MRI, the very expensive cost of MRI, and the expertise for MRI interpretations. But MRI does have a unique role in disease activity monitoring because I suggest I've talked about in the previous slides. It has the clinical disease activity score has limited ability in differentiating whether the MRI whether patients got inflammations, or patients not got no inflammations. So this is one of the earlier publications showing you this this fact. Now, having said that, from our publications 2 years ago, we validate AXDAS, the ankylosing spondylitis disease activity score, using a new kind of imaging, the diffusion type of MRI imaging. So what we see is in patients with active disease, so in patients with definite MRI inflammation, AXDAS actually correlates with the SPARC score. Is one of the MRI score that could measure the area of inflammations, and the ADC score. So the ADC basically reflects the intensity of inflammation. So SPARC score reflects the extent of the MRI lesions. So the ADC actually correlates quite well with AXDAS, and this only applies to patients with features of MRI inflammations. If patients got no features of MRI inflammations, this is not applicable. Now, finally, I'm going to talk something about the future trend of MRI as a personalized medicine development. So basically, there are two new trends of development. So the first one is full body MRI. It could measure total body inflammation load. Now, this is the photos showing you one of the whole body MRI applications, and this is believed to be one of the way to assess the amount of inflammation in the body as as a whole unit. So this is not like the spine MRI or SI joint MRI, which could only see the inflammation load as a part of the body, but then this is a whole body inflammation assessment. The other one is diffusion weighted image. The good thing about this is it could assess the intensity of inflammation, and this is something the STIR image couldn't do. And this is one of our earlier publications in 2019. We proposed using the apparent diffusion coefficients as an imaging markers in axial spondyloarthritis for the spinal disease. So this is just to show you how we perform diffusion weighted images. So on the left-hand side, this is the traditional STIR image, which shows a hyper-intense area representing disease activity in the lumbar spine. So the middle one is the diffusion weighted image, and and then the right-hand side one is the ADC map regenerated. So from the ADC map, we can measure the intensive inflammation, and it could be represented by a number. So based on this, we generate two sets of number from the images, the ADC map. One is the ADC max, the maximum intensity of inflammation. The ADC mean is the mean intensive inflammations of the measured lesions, and we do some adjustments, numbers adjustments, because we try to compare the ADC with the reference area, and that's the normal area of spine without any inflammations. So we compare the numbers with a number of clinical disease activity assessment tools. So what we find is we also compare the SPARC score, traditional SPARC score, with disease assessment tool. So what we found was the ADC values actually correlates better when compared to the SPARC MRI score. In the SPARC MRI score, from our study, only BAS3 correlates with the SPARC score. But then if you took a look at the ADC values, it correlates with BAS3, BAS-G, pain score, as well as the stiffness score from the BAS side. Now, it looks like the ADC value is only very theoretical. it could be quite difficult to measure the numbers in real day practice. So this is one of the other area we are working on nowadays. So this is one of the publications published in February this year. We are trying to use the technology of artificial intelligence to help us to interpret the imaging. So this is the left-hand side is the image, the lesions we've seen, and the right-hand side is the lesions identified by our artificial intelligence deep learning algorithm. So you can see the deep learning algorithm could actually perform quite well in identifying the SI joint information. The theory is we try to teach the image using a whole set of database. We have two kinds of database. One is the original database. One is the, what we call fake color image database. Fake color image database basically is incorporating different levels of images and teach and we can teach computers so that we can teach computers to interpret the images using the nearby images. It's just like how we read the MRI. We apart from reading the image, we also read the image up one level and down one levels for more accurate image assessment. So we break the images data down using a deep learning algorithm program, the attention unit, and then from the breakdown image, we teach computers which one is positive, which one is negative, and then we pull the data again, we pull the images again, and we form the image, and then it could tell us which one is positive image and which one is negative image. Now, at the current level, we can use this deep learning algorithm to identify the inferential lesions in the spine and SI joint. And then what we're doing right now is we're trying to teach deep learning algorithm to score the MRI images. For example, the SPARC score. And then another step ahead, we're planning to teach deep learning algorithm, the AI, on how to do the DC score. If we can do that, things will be easier for our daily practice. We can just feed the program with these images, and then automatically it will generate a score. And if you do an MRI, say after biologic treatment, you can always feed a new MRI to the program, and then it could tell you how much the response could be, like 70% or 80% response. By measuring the ADC, you don't even need to know how to interpret the MRI scan. So this is the proposed future personalized medicine. We can quantify the SPARC image, which we think is more powerful than the visual assessment. Machine automated assessment could definitely help in our interpretation and clinical disease activity assessment. And by doing these directions, we could hopefully improve the accuracy and precision of the MRI image assessment in axial spondyloarthritis. So thank you.
Thank you, Dr. Zhong, for this summarizing the latest advances in MRI for diagnosing axial spondyloarthritis, assessing and monitoring disease activity, as well as to let us have a glimpse of what is going to happen in the future. So we will be back for a moment for the Q&A. Now, for all the participants, so we welcome all of you to send in questions if you have any, and you can use the chat box, and then we can take a look at your questions, or you can use the raise hand function, and we can then unmute you, and so that you can talk to us. Now, while we are waiting for the questions, perhaps I can start. Professor Griffith, so I think thank you very much for enlightening us on the utility of using low dose CT as a diagnostic tool. So, for example, in Hong Kong, we have a very long waiting time. So, do you think for MRI, I mean, so do you think that now is the time that we should, just as you have mentioned, move away from actually ordering X-ray, and we should just order low-dose CT as the first step for diagnosing patients with ankylosing spondylitis, axial spondyloarthritis?
Yeah, thanks, Laishan. I really do believe that's the way we should be going, really, hugely, because it's been very enlightening to me to do this lower dose CT study. You know, even though I've only done a small number of patients, it's even still been very enlightening. I think that essentially low dose CT is not difficult to do, right? But it's just the demands on the CT scanner are quite high, you know, as you know. So while CT is much easier to get than an MRI scan, it's still not, you know, completely open as it. And so provided we can sort of limit it to a few, you know, patients, you know, each week, then I think it's very reasonable to go along those lines. Is so much better, honestly, as for the first diagnosis. In other words, to establish an sacroiliitis and my feeling is that I've not come across any patients who have had an abnormal CT who've had a normal CT who've had a normal or an abnormal MRI examination. You know, because of course MRI shows osteitis and enthesitis, but in my experience, and it's limited to the 43 or so patients who have scanned so far, all of those patients have had changes of sacroiliitis and MRI. MRI are on CT. We haven't come across any patients who have had a completely normal CT and have had, you know, evidence of sacroiliitis on MRI. So I suspect CT may be even better than we consider it to be at the moment.
James, if I might ask a question too, great talk for both of you. James, on the CT, so say if I was a clinician and I want to order CT, the first thing a patient asks is 6 X-rays. What's that like in terms of background radiation? Is that a significant amount or a concern for the patient?
No, it isn't. I mean, like anything, Paul, you know, the benefit has got to be weighed up against the potential risk. And as a one-off investigation, the risk is minimal. Really is minimal risk because the radiation dose is very low. But if you were in the situation where you maybe had a younger child and you wanted to follow up that child with serial MRI or serial CT examinations, then that would not be the way to go. You'd be much better off to follow it up with MRI examinations. But as a you know, it's really, no, the radiation dose is not a concern really, Paul, relative to the sort of benefit of CT.
Yeah. Are there any things that you mentioned, you quite nicely outlined there, ankylosis and sclerosis and erosions? Are there any particular features when you look at a CT SI joint that really raise your probability that that person has spondylopathy?
Yes, because, you know, effectively first there's the absence of any changes related to osteoarthritis, you know, so there's the absence of marginal osteophytes and any joint space narrowing. So if you see a lot of sort of small to medium-sized erosions in the patients like that, that's very indicative of sacroiliitis. Always the situation is really, the main sort of concern are sort of problematic areas is either in younger ladies with osteitis condensis alii, or else sort of middle to elderly patients with coexistent osteoarthritis. These are, but in young patients, it's not really an issue.
And just one more follow-on from that, we often struggle with MRI in the postpartum because those changes to postpartum they cause all sorts of confusion. Can CT help us there? Do you think? Does it take? Yeah.
Yeah, I think so. I've been speaking to LS about this, recently we've both been speaking about it before, because, as you know yourself, Paul, the MRI thing about sacroiliitis is evolving, and 5 years ago and before that, people used to consider any sort of bone marrow edema alongside the sacroiliac joint as sacroiliitis. So a lot of patients were overcalled as having sacroiliitis at that time, but now people are more clear about the sort of stress-related changes. I think if you're using those erosion-specific sequences, the added value of CT is less, honestly. But, they're basically high-resolution 3D sequences that sort of accentuate the cortical outline. And so, but even with that, occasionally, maybe in a very small percentage of patients, I might do CT as well. So in a very small number of patients, CT is helpful for problem solving.
Yeah, I liked your algorithm. I thought that was good. Problem solving with the MRIs gives you trouble.
Yes, thank you.
So perhaps we can change the topic a little bit and ask about the utility of MRI for disease activity monitoring. So, Ho-Yin, you mentioned that MRI is also very useful in monitoring disease activity. But first of all, if the patient is clinically responding, when should we consider repeating an MRI? And there's also a question from our audience. And what do you do if the patient is, responding very well, but there's still signals on the MRI?
Can you hear me? Right. Usually I don't order MRI for disease activity monitoring. No, it's because of the cost. The MRI cost is very expensive, and in Hong Kong we require at least a year of waiting for disease activity monitoring. This is the most important reason, and the other reason is from our data, as I have shown in the slides, the axis actually correlates with the MRI disease activity score, but that only applies to patients with MRI information only. So patients with fibromyalgia, of course, they got a higher disease activity scores, and that disease activity assessment is basically not reflecting the inflammations. But in case patients with persistent disease activities, and we want to make sure this is not another problem like mechanical cause, infections, or even malignancy, you order MRI, and that would be the only way to accurately assess the spine or the SI joint. Clinical disease activity score basically can tell us nothing, and just like Professor James Griffith, Professor Paul has just said, quite a number of lesions could be quite difficult to interpret. Especially we're not so sure which one is mechanical, specific lesions, and which one is spondyloarthritis specific lesions. And at the moment, my proposal is, we have to correlate with clinical. We have to interpret it with the clinical context. So I hope I can,
it's responding well, and somehow you repeat an MRI, there's still some inflammatory changes. You would not change your management, right?
No, probably no, because at the moment we're not too sure which one lesion is specific to spine, to spine, which one is not, and honestly, there's no data to show us, how much we should, treat the patients, and the so-called treat to target. What it means to absolutely no information in the MRI, we're not sure.
I think Chung, you'd agree too that a lot of the time the edema takes so long to resolve. So if patient gets better, you repeat the MRI too early, it's still going to the air. The other problem we run into in Australia is that you might do an MRI, as you say, there's a clinical problem, you're trying to work out a year down the line whether it's mechanical or not. And the report comes back and says there is sacroiliitis, and what the radiologist is referring to is sclerosis and erosions, not actually active disease. So it can be a minefield when you do a follow-up MRI, can't it? Can be difficult.
Yeah, we we got the same problem as well. Radiologist tends to report spondyloarthritis as, erosion, and the structure changes, erosion, ankylosis, and sometimes if the rheumatologist is not looking at the MRI, not that expert looking at the MRI, they take it as a disease activity.
That's right.
Okay, so back to James. The audience was asking, we are all quite convinced that low-dose CT is very useful as a diagnostic tool. So who should be ordering this? How about primary care physicians or non-rheumatologists or orthopedics, or should it be just after seeing a rheumatologist? What do you think?
Yeah. No, I think, honestly, I think we should just get to the stage, a situation where we're not doing radiographs of the sacroiliac joints anymore. For these patients, we should just proceed to low-dose CT. So at the moment, a wide range of specialties refer patients for sacroiliac joint imaging. But I would have thought that I'd like to just stress two parts of my talk that I think were quite surprising to me. The first is that in a small percentage of patients with barn door normal sacroiliac joints on X-rays, they had sacroiliitis on low-dose CT, about 10%. And similarly, even more surprising and probably more worrying is that about 10% of patients with what I consider barn door sacroiliitis on X-rays had normal CTs. When I say normal, I don't mean normal, of course, as in normal. I mean normal as in no sacroiliitis. Do you understand? They obviously had osteoarthritis or osteitis condensans ileae, but not sacroiliitis. So that was surprising to me that, if we're doing radiographs, there's a potential that we may miss a certain percentage of patients and call them normal, which is well known, but there's also a potential that we may also overcall some patients and call them and label them as having sacroiliitis wrongly as well. So basically, it would be very helpful if they were seen by a rheumatologist, because a rheumatologist isn't the best person to act as a gatekeeper to stop so many patients being referred for low-dose CT. That's the short sort of answer to the question. But I think we should work towards not doing CT, not doing radiographs, but just moving towards low-dose CT for patients with suspected sacroiliitis.
Certainly makes a lot of sense. I think we did a study a few years back where we took radiologists and rheumatologists. We got them to do New York grading on X-rays at baseline and do MRI grading of edema. Then we trained them for 2 days. And at the end of the 2 days, there was no improvement in agreement in the SI joint X-rays. So even if we trained them for 2 days, but in the MRI osteitis and the CT training, they did improve. So training and calibration. So it just goes to show you, as you showed, how difficult it is to interpret a 3D structure in that one dimension.
Definitely. But then we still need to consider the cost, right? So I understand that, for example, in Hong Kong, MRI is like 500 US for the SI joint, roughly.
Yes.
But for the CT SI joint, the cost is probably like $250 US. So it's like half the price.
Yes.
Yeah,
that's right. Because of course you're paying for the patient to come along, get put on the table, and have the scan and report. You're not actually paying per radiation dose. Because the low-dose CT, it doesn't mean the cost follows the radiation dose.
Yeah. How about the duration of the examination? Because MRI, SI joint probably need at least half an hour, and it's very noisy and it's not comfortable.
Yes.
So the CT procedure will be much shorter and more comfortable, is that?
Yeah, that's a very good point, LS. It's much more comfortable for the patient, really. And the examination is very short. Of course, the actual scan time is less, maybe only a minute or two, but the whole time with CT is getting the patient into the room, getting them on the table, setting up the scan. Well, the actual scan time will be quite short, but the whole process will still take 15, 20 minutes.
Okay. Now, there's another question from our audience. So in our XBAR patients who are already on therapy, could sacroiliitis change with time, becoming more like degenerative or osteoarthritis and get confused with active disease when checked by MRI or X-ray? Is that possible?
Sorry, Alice, I think it's possible. It would have to happen over a very long period of time, really. No, I just like to make one other point, if I could, James, about the changes, about diffusion weighted MRI and all of these changes, and AI as well, because AI also cannot differentiate. Whilst AI is good for looking at, recognizing bone marrow edema, recognizing erosions, but mainly bone marrow edema, as James has shown, it cannot differentiate between stress-related bone marrow edema and bone marrow edema related to osteitis. That needs a much broader sort of clinical and imaging sort of input to make that distinction. The other thing I'd like to stress to everybody is that certainly it's good to put a lot of reliance onto imaging with respect to making a diagnosis of sacroiliitis. But I think everybody should also realize that it's not always that clear cut. And in those situations also, you need the bigger clinical sort of picture as well. That is important to realize that, whilst it's good to put reliance on it, at the same time, not undue reliance should be put on it as well.
So
yes,
there
are ambiguous cases.
I kind of agree. In the daily practice, I always compare the images with the clinical pictures, like the site of pain, site of inflammations. We compare with each other, and we compare the clinical characteristics as well, because a lot of time I find it so difficult to interpret the MRI images, whether this lesion belongs to degenerations stress related, or these lesions belongs to spondyloarthritis. So I kind of agree.
So the audience was also asking, for example, I guess the scenario is like this: this patient with suspected axial spondyloarthritis, and then they were given NSAIDs for 2 weeks, and then to have an MRI. And would you think that this kind of treatment would affect the MRI images? And what's your opinion?
Honestly, I don't think it will affect it, honestly. If you take a look at the European data, only 15% of patients, taking clocks or NSAID from, I cannot remember the duration, it must be more than half a year, will have the MRI changes. I'm not sure this changes is due to NSAID, COX-2, or spontaneous remission. So I don't think NSAID or COX inhibitor would matter that much.
Yeah, I think you're right. I mean, I know why the question's there. It's the most common question that I think we get asked about MR imaging and practicality, because, you think prostaglandin is being inhibited, reducing swelling, maybe it'll affect it, but there's no data to suggest it does at this point. Steroids, sure, if you want to stop steroids, but NSAIDs, no, they don't appear to affect the outcome, at least on the data we have to date. It may change.
So how about this patient with suspected axial spondyloarthritis? So I guess for now, most of the people will still perform X-ray, and then if there is negative, then we will ask for an MRI. And now we are proposing perhaps CT, low-dose CT. How about in this patient, either they have CT or MRI didn't show anything. So what would be the time frame for us to wait before we should order another imaging to see whether the patient did develop evidence of sacroiliitis?
Yeah, I think that's a very practical question, really, because and honestly, we don't know the answer, but the longer the better. The longer you wait, the better. And it would definitely need to be something like 9 months at least to a year, not sooner than that, because you're going to have to definitely take that length of time to develop anything sort of from going from a normal situation to a sort of a definite abnormal situation. So I'd say definitely 1 year at least, or 9 months to a year less, really, if that was the situation.
Yeah, that sounds reasonable.
It's quite a reasonable one. It also, I suppose, depends on the patient's clinical state and how much pain they've got and the pretest probability. But I think you're absolutely right, James. Waiting longer allows you to get more change.
Yes.
Yeah. And then there's another question asking about your opinion and experience to use Vibe MRI for SI joint. Any experience?
James,
I haven't used this Vibe MRI, it's a 3D MRI, but I think the Professor Griffin might have some opinion on that.
Yeah, go ahead.
Yeah, sorry. Vibe is basically what I termed as like the erosion specific or erosion sensitive MRI examination. In other words, it's a 3D high resolution 3D image which accentuates the cortical margins of the sacroiliac joints and allows you to see erosions much more specifically than with standard T1 and T2 weighted imaging. So we use that routinely now with all sacroiliac joints, and it's really the go-to sequence looking for erosions. And in that sense, that that's the reason really why if you have good quality imaging with MRI, you're not going to see an awful lot more on low dose CT in a large number of patients because of this sort of more useful sequencing.
Okay. So, you also mentioned, the new development of like whole body MRI. So, what's your opinion regarding the utility of this whole body MRI? Would that be useful for us?
I noticed the proposal, but I haven't tried it before. But supposedly this would be detection of the whole body inflammations, and I think the time required to do a whole body MRI must be must be quite long. I mean, I suspect it would be an hour or something, But the good thing about it is you can see a lot of information other than the axial joint, like enthesitis or peripheral arthritis, and if in terms of treatment decisions, like whether we should use biologic or not, I think that part of the information could help as well.
It's an interesting technique. I've been working on this with the MRI OMRAC group. So if you Google MRI wipe score, you'll find the scoring we've been doing. It's going to be interesting. You're absolutely right, I think, in particularly trying to help differentiate those people. Those people you see that have got spondyloarthropathy, but you're not sure if they've got fibromyalgia. They're tender everywhere, and clinically it's difficult.
Yes.
And it may allow us to try and differentiate those people, also to estimate disease burden a bit better in people. So yeah, certainly it looks to be promising, but you're quite right. It's 40 to 60 minutes in the magnet. It's not and it's expensive, but it's usually done just with the stir, so there's no contrast. But it's in its early stages, but I think it's going to have utility. In research, we're using it now. In practice, probably a way off yet.
So what do you think, James?
Well, if you do, the important thing is to not to be, if you do whole body MRI in a large number of patients with I'm not talking about young patients now. I'm talking about middle-aged to more elderly patients, right? A large number of them will have changes very similar along all of these sort of ligamentous and muscular attachments that can simulate spondyloarthropathy. But I do agree with Paul that it might have a role in people with potential polymyalgia. It's related not to it's the overall accumulation of disease rather than the actual point specific presence of disease. That's the important feature there, I think.
That's right.
The overall sort of what level of disease they've got with respect to all of those areas of edema at the muscular and ligamentous attachments.
James, if I may ask a question, James and Chung Ho, the diffusion weighted imaging, interesting. It has been used in rheumatoid and the ADC maps have been used. Just interested in your opinion on I mean, how you showed some nice data there, but how good do you think it is really in differentiating patients who have sacroiliitis from just a normal stir sequence?
I think we have another validation study on that. I don't think it works better than the stir image in disease diagnosis, because if you take a look at the DW image, the resolution is much worse than the stir image. The only good thing about DW image is it has ADC value, so it can measure the intensive inflammation, and I think that could provide us another angle to look at the disease. So, like maybe in the future, for research purpose, the ADC value could tell us whether patients will have increased risk of ankylosis or increased cardiovascular risk or stroke risk. We never know, and that could be a possible research agenda.
Yeah, we should explain. Its ADC refers to attenuated diffusion coefficient, and so it was initially developed in stroke to measure water diffusion through, and that's how stroke was diagnosed. Was able to diagnose early, but that's what you're using in the SI joint, is that ADC value, aren't you? How that water's moving through. Yeah.
There's one drawback about this ADC. We find it quite. Different machines will generate different different ADC values. So our proposal is we probably need some adjustment for the ADC, or else patients with different machines cannot compare. So we're proposing in the previous study, we're proposing to compare it with a normal spinal ADC, but we're not too sure if this is the correct way. If we can do it in the using AI program, things might be easier. We can easily take the FH normal ADC values of the whole of all the spinal unit, but then this is still something we need to think about.
Yeah, James, what's your opinion on the DWI and ADC?
Effectively, it's just really showing bone marrow edema, in a more sensitive way, but you're downplayed by the limitations with, as James mentioned, machine variability and large, very poor signal to noise. So, I mean, it's potentially in the future, maybe a more objective measure of the level of inflammation with respect to the bone marrow edema, in the sense that you can it provides you a measure of water diffusivity. So you can imagine, as opposed to bone marrow edema is very different to soft tissue edema. That's why it doesn't respond, of course, to you won't see such dramatic changes in bone marrow edema as you'll see in soft tissue edema. It just takes months and months and months to settle down, as opposed to, you can see changes very quickly in the soft tissues. But and in enthesitis and things like that. But I think it's a long way in the future before we'll ever begin to use those sort of things in a day-to-day manner, because it's really just there's too much post-processing and too much variability, and how you perform the sequence and everything like that is good in a standard cohort, but will never enter clinical practice, not in anything like the immediate future.
Okay, so we are talking about the future, right? So what do you think about the utility of these AI in terms of reading this imaging? So James, are you going to be replaced by the AI very soon?
No. I mean, me, I think imaging is the future of medicine. I think imaging is just so powerful a tool. And radiologists cannot cope with imaging. The demand for imaging is insatiable, and quite rightly so, because imaging is so helpful, honestly. And that demand is not going to go away. Do you know what I mean? It's going to increase and increase. So radiologists need AI badly, because they cannot cope with the amount of imaging that's required at the moment. So we all need AI to read, images, and definitely will replace radiologists. I'd imagine maybe in 50 to 60 years, it probably might be well. I probably not know I've no plans for what I do. Basically, I basically, look at
Not very.
which a machine can do.
Mhm.
But we have to realize that we all clinicians, we all do the same thing. Do you know what I mean? It's not just my job is going to be changed by AI, but all of our jobs are going to be changed by AI. And we need AI to sort out a lot of the stuff which is normal and which doesn't need and we need, these sort of tools to allow us to focus on the sort of more tricky sort of aspects, which will be good for education, research, and everything.
Mhm. So
I'm very much in favor of it, but I think overall there's a huge amount of work that needs to be done with respect to standardization and everything like that. But definitely, I would very much encourage any research in that sort of area.
Yeah, so that the AI can help us do all the mundane things, so that to save our time. Yeah,
but that's the very one big aspect of AI, which is excellent. It provides you a very good objective quantification, so for quantifying levels of osteitis, the actual amount, putting a measure on the amount of bone erosion, on a measure on the amount of joint space narrowing, all of these sort of things is excellent for AI, really.
Yeah.
Rather than saying mild, moderate, severe, you get a definite measure. It's a reliable, definite measure. It's much, much more helpful.
Mm-hmm.
I've no doubt in the future, a lot of the MRI examination, imaging investigations will come out with a sort of a chart of parameters, just like you get a blood test result. Your heart size, the whole thing will be all there as well, blood and bone density, etc.
Yeah. So now back to the MRI. So we are aware that a lot of the imaging really depends on experts who have a lot of experience in reading the images before we can say with confidence arrive at a diagnosis of whether this MRI image is diagnostic of sacroiliitis or not, right? So and I'm aware that they have a criteria from the ASAS for the criteria, but then it's not very specific. So I'm just wondering whether, Paul, are you aware that are they going to have a revision on the criteria
Yes.
or what's going to happen?
Yes, it's constantly being revised. I think the big revisions you'll see will be, so at the moment we rely a lot on osteitis, and as you know, it's got that diagnostic threshold of, 2 lesions in one on either side of the joint in one plane, or one lesion over several planes, and that probably will be revised over time. But the big thing that will come is including structural things. Because at the moment, I think most radiologists, when they're reading, they'll see the osteitis and then they'll look around for the other features that say, okay, this is probably a spondyloarthropathy, there's an erosion, there's a sclerosis. And so a lot of the work at the moment is trying to work out the sensitivity, the specificity, the reliability between readers of fat metaplasia, for example, sclerosis, erosions, because those things probably, if you look at cohorts, a nice cohort Michiel Ostergaard published a couple of years back. And what he did, he took cleaners in hospitals, runners, post-pregnancy women, and people with spondyloarthropathy. What he was able to show nice was osteitis runs through all those cohorts, so it can be hard. But the things that really pulled them apart was sclerosis and erosions. So that if you saw those things, it was much more likely the person has spondyloarthropathy. So answer your question, yes, they're constantly being revised. But I think what you'll see next is that those structural things coming in to help us make the diagnosis.
Right. Okay, perhaps we have one final question. So, Ho-Yin, you've been, telling us that the utility of doing the MRI spine, for diagnostic purpose, if you see those corner lesions and so on, you probably don't need to go to the SI joint. But how often? Normally we go to the MRI SI joint first, right? So how often do you see only lesions in the MRI spine, but not in the SI joint?
Not often. No, most of the time, when you see spine lesions, you will see SI joint lesions. So that's why we don't propose a replacement of spine MRI replacement of the SI joint MRI by the spine MRI. What we're proposing is, because a lot of time orthopedic surgeons or family physicians are doing the spine MRI instead of SI joint MRI for back pain. So if we see a lot of corner lesions or fatty corner lesions in the spine MRI, we probably don't no need to scan the SI joint, because we can save some money and we can diagnose the disease quite confidently. So this is kind of some of the money saving approach, because MRI is not an inexpensive investigations. So this is simply a proposal. So we're not proposing replacing it, SI joint MRI with a spine MRI, not at all.
Thank you.
It's been an excellent session. I think we've all learned a lot from not only the presentation but the discussion. Thank you to Laishan for presenting and for co-chairing and chairing so well as always. Helped pull the discussion along very well, and thank you very much for your expert steering of the webinar. And to both of our speakers, thank you so much. Excellent presentations. I learned a lot, and your discussion was just first rate. It was great to have that to and fro of the conversation and to learn a lot from you. So thank you very much, everyone. We'll sign off now and we'll officially close the session. And thanks everyone for your attendance.
Yeah, thank you, Paul. Thanks.
Thank you.
Yeah, bye-bye. Thanks.
Thank you. Bye-bye.
Yeah, bye-bye. Thanks.